Okay, thanks so much everyone for joining us. We're excited to have you all here. We're working really hard to get some speakers in over the next little bit with some really interesting topics that have been kind of on the horizon. So my name's Nicole Kurtz. I'm the Vice President of the Crisis Workers Society of Ontario and a registered social worker who works as a mental health clinician supporting civilian and uniform officers of the OPP. So just in terms of housekeeping, if I can just kindly remind everyone to keep their mics muted, and I'll encourage anyone who has questions to just put them in the chat, and then the speakers will address them. We'll leave about 10 minutes at the end to address questions, and I'll moderate the chat. For everyone's awareness, we have started recording this presentation, so it will be posted on our website in the future for people to view it. But that will take about a month or so to upload, so your patience is kindly appreciated. And we're really excited to welcome our two guests. So we're going to be talking about medical assistance in dying, glass half full or half empty, which will be presented by Dr. Brian Furlong and Doug Mason. So Doug completed his Master's of Science degree in Occupational Therapy at Queen's University and has been working on the Fergus and Guelph Assertive Community Treatment team at Homewood for the past 10 years doing frontline work, and most recently moved into a management role. So welcome, Doug. Thanks so much for being here. And Dr. Brian Furlong, he completed his medical school training and residency training at McMaster University and completed his physician leadership training at York University. He was a faculty member at McMaster University for 25 years and currently works as an ACT with Doug as a psychiatrist with the Fergus ACT team. He's worked with Homewood for the last 30 years, and over this period of time has served in various roles, including acute care, emergency mental health, ECT director, chief of regional services, and chief of staff. In his addition to his current role with ACT, he's also involved in completing MAiD consultations. So we're super excited for you folks to be here and joining us with this really interesting, controversial, and great topic. So I'll pass it along to you. Thank you so much.
Great. Thank you very much for your kind words of introduction, and greetings to everyone that's online. Kind of wish we were in person, but this is kind of the lay of the land that we're working with, and so we'll make the best of it. So in the interest of time, we're going to jump right into things, and I'll start by just reviewing what our objectives for the session are. Before doing that, let me just say to you that this presentation is not meant to advocate strongly for or against MAiD, but instead to simply provide the current state of MAiD in Canada, what some of the processes are, and what some of the challenges are. So in terms of objectives, we're going to look at the eligibility and assessment process currently in Canada. We're going to speak about the whole issue of solely mental health conditions in terms of MAiD and how that contrasts with the issue of patients that have terminal physical conditions. And we want to have some time to explore some of the clinical, legal, ethical challenges that we all have to deal with when it comes to MAiD and thinking about mental health conditions. Now, having said that, I want for everybody to grab a piece of paper of any kind in front of them. And at the start of our presentation, I'm going to ask 5 questions. And they're not 5 questions that we're going to ask you to post answers to online, or we're going to ask you to share with anybody or submit with anybody you're going to get a grade on. It's kind of a little bit for you to know where you stand at MAiD in terms of MAiD knowledge, with some common elements that come up and then we'll come back to those same questions at the end. So if you don't have a piece of paper, but you have a pen, you can write on your hand if need be. So let's just jump into them. And the questions are all in reference to MAiD legislation in Canada as it exists today. So the first question is, in regards to MAiD, the individual must have a terminal illness to be eligible for MAiD. Write on your piece of paper if that's true or false. We're going to move to the second question, which is that the person cannot have refused treatment that the doctor believes will be effective in treating his or her condition. Indicate true or false. Third question would be, a person with a physical illness and a psychiatric illness can be eligible for MAiD. The fourth question, any healthcare professional can initiate and engage a patient/client in discussion about MAiD as a treatment option. True or false? And the last question is, a person with a primary diagnosis of dementia is not eligible for MAiD. True or false? So set your piece of paper aside and we'll come back to it at the very end. And if both of us forget, somebody online will remind us. So having said that, we're going to divide things up in our presentation, and I'm going to hand over to my colleague, Doug, who's going to steer you through some portions of the presentation, and then you'll hear from me again shortly.
All right. So you might be wondering why there's a picture of, well, it looks like the west coast of Canada. And I just wanted to point out, my good friend took this of Malign Lake in Jasper. And I think it, from my point of view, I know we're speaking probably mostly to Ontarians, but MAiD is an issue that every province, territory across the country is going to be sort of grappling with, especially when it comes to mental health disorders. And so I think it was appropriate to have pictures from across the country. And I like the picture. So to start off here, my goal is to try and give us a little bit of insight into how we got to where we are today. Some of you may be familiar with the Carter v. Canada case. This was kind of the first landmark case for MAiD in Canada, where in February of 2015, the Supreme Court, which you can see on the slide there, ruled in a unanimous decision to strike down the provision in the criminal code and granted certain Canadians access to MAiD. And the criteria from that ruling that was required to be met was that the individual had to be a competent adult who consented to the termination of life and have a grievous and irremediable medical condition which causes them enduring and intolerable suffering. So those were kind of the three criteria that needed to be met. For the first time in Canadian history, MAiD was legal, and the courts gave the federal government 12 months to amend the criminal code and to develop new standards. Now, what I think is important to note in this ruling was the criteria did not restrict those with a mental health disorder from accessing an assisted death. We fast forward 12 months to 2016, the federal government developed Bill C-14, which outlined, again, the specific set of conditions that were acceptable for MAiD in the criminal code at that time. These added some restrictive elements, which included that the individual must be in an advanced state of decline and that their natural death must be reasonably foreseeable. So it went from fairly broad to a little bit more restrictive. And then fast forward again to 2021, Bill C-7 came into existence. And what that really legislated was another amendment that created what we call Track 2. And that is for individuals whose death is not reasonably foreseeable And I'll be coming back to the notion of these two tracks over the upcoming slides. A key piece of this legislation was a provision prohibiting MAiD where a mental disorder is the sole underlying condition. And in literature, you may see that as MAiD, MD, SUMC, just to shorten it up. And this sunset clause was supposed to be for a period of 2 years and was supposed to be lifted on March 17th, 2023. Now, of course, we know that that didn't happen. As that deadline was approaching, Bill C-39 came about, which kicked the can down the road another year and delayed MAiD for mental disorders as the sole underlying condition until March 17th, 2024. In the lead up to that, the Canadian federal government tasked the Special Joint Committee on MAiD with assessing the country's readiness for MAiD requests for mental disorders. And 3 months ahead of that March 17th, 2024 deadline, the committee released the report in January, which concluded that the medical system was not prepared for such requests. And ultimately, the decision, the Canadian federal government has delayed this decision until 2027. As mentioned previously, the Special Joint Committee was looking at the level of preparedness, and they were looking at 3 main areas, and those being what practice standards existed at that time, what training, education, and professional development was available, and what kind of oversight the provinces and territories have in place to ensure that there is consistency in best practices adhered to. Ultimately, in its findings, MAiD for mental disorders, the Joint Commission ruled that MAiD for mental disorders should not be available until the federal government is satisfied it can be safely and adequately provided. And then the other recommendation of that report was that 1 year prior to that newly anticipated law changing, that this committee come back together to reconvene and assess the level of preparedness. And that brings us kind of to where we are at today, where we're sort of in this waiting period, where the expansion of MAiD for mental disorders is currently on hold. However, we do have some idea of what it might look like based off of what the current MAiD process and framework in Canada that exists today. So switching gears to what it sort of currently looks like, I'm going to talk about the 2 tracks that I mentioned earlier, where track 1 refers to the procedural safeguards that are in place for patients whose death is reasonably foreseeable, or RFND. And track 2 refers to the safeguards for those whose death is not reasonably foreseeable. So there's, or non-RFND, 2 distinct tracks that a patient would fall under if they're requesting MAiD. There are specific set of procedural safeguards depending on which track an individual falls under. And I'll go through track 1 first. So track 1, the first procedural safeguard is that only physicians and nurse practitioners are able to perform a MAiD assessment, and they must determine that the person meets all of the eligibility criteria. So not some, not most, it has to be all. Both the physician and the NPs must be independent. So for example, this means they cannot hold a position of authority over the other, or cannot be connected to the other or to the applicant or requester in any way that could affect their objectivity. This next point has a few parts to it. The first being that the request has to be in writing, signed, and dated by an independent witness. And the second, that they must have been informed that they have a grievous and irremediable medical condition. The person must give informed consent to receive MAiD after having been made aware of the means available to relieve their suffering, and this would include palliative care. And the person must be informed that at any time they may withdraw their request. If the individual has difficulty communicating, all necessary measures must be taken to enable them to communicate. And the last piece for track 1 is that immediately before MAiD is provided, the individual is given a last opportunity to withdraw their request. So those are all the procedural safeguards for track 1, where the death is reasonably foreseeable. When we move to track 2, it includes all of those ones I just touched on, as well as some additional safeguards that must be met. The first one being that if the assessors do not have expertise in the area of the patient's condition, they must consult with a physician or MP who does. I think most people would recognize that there's various kinds of supports available to help somebody with their suffering. These supports may range from counseling, disability support services, community services, and palliative care, and the patient needs to be made aware of all of these. In addition to having discussed the available means to relieve suffering, both assessors must be satisfied that the patient has given serious consideration to those means. And lastly, for track 2, a minimum of 90 clear days must pass between the first assessment and the provision of MAiD. Now, again, it's worth noting here that the vast majority of MAiD requests for mental disorders as the sole underlying condition would likely fall under track 2, where their death is not reasonably foreseeable. Regardless of which track one falls under, 1 or 2, in order to be eligible for MAiD in Canada, the individual must meet all of the following criteria. And that is that they must be eligible for government-funded health services, so being funded by the province, territory, or the federal government. They must be at least 18 years of age. Sorry, I'm having trouble with my mouse here. Must be at least 18 years of age. They must be capable of making decisions with respect to their health. The request for MAiD must be voluntary. In other words, the assessors must be satisfied that there is no external pressures. The individual must provide informed consent, and they must have a grievous and irremediable medical condition. Now, we've heard these words a few times now. So over the next few slides, I'm going to try and tease this apart and define exactly what is meant by the concept grievous and irremediable medical condition. Amendments to the Criminal Code of Canada provide a definition of what is meant by grievous and irremediable. And basically, there's 3 main components to it. 1, that the person has a serious and incurable illness, which is causing an advanced state of irreversible decline in capability, and it is the illness that is causing them enduring physical or psychological suffering that is intolerable to them and cannot be relieved under the conditions that they deem acceptable. And again, we'll drill down on each of these 3 main components over the next few slides. The first concept we'll zoom in on is the meaning of incurable. And Health Canada has arrived at incurable as a definition, which essentially boils down to having no reasonable treatments remaining, where reasonable is determined by both the clinician and the individual together. The next concept or component of grievous and irremediable medical condition is the decline in capability, which essentially refers to the loss of the ability to function in the areas deemed important to the person, and whether that be the social, occupational, academic, or physical realms of life. And the last component I wanted to highlight is the notion of intolerable suffering. This speaks to the fact that the suffering for an individual can be both physical or psychological in nature. The suffering is deemed intolerable to the person, and the suffering cannot be relieved by the conditions that the person themselves finds acceptable. And that is the 3 main components of the grievous and irremediable medical condition, which I think it has value in teasing it apart, because it can be a little bit ambiguous when you first hear it. And that brings me to the end of my section. Now I'm going to turn it over to Dr. Furlong, who will provide a brief picture of the recent MAiD data in Canada, as well as the responsibilities of clinicians and healthcare practitioners regarding MAiD requests, and then conclude with a discussion on some of the inherent challenges for MAiD where mental disorders is concerned.
Thanks, Doug. I'm just going to position myself a little bit differently here. So I'll start by saying to you, I wanted to balance the west coast of Doug's photo with the east coast, with a glorious iceberg in the background, which is in keeping with my origins from the east coast. So I think so. Launching into this slide, it is important to talk about the total number of MAiD deaths in Canada. And we see that MAiD started in 2016. And when you look at in 2016, there were just over 1,000 individuals that were the recipients of MAiD. That actually was from a half year in 2016. But each year you see a progressive increase in the number of deaths, to the point that in 2023, which is the most recent Canadian data we have, which is actually quite fresh off the press, and we see that there were over 15,000 Canadians that did receive MAiD. And I think this is a good place for me to say that therefore there are a couple of reasons to say that as a group, crisis workers should be aware of MAiD. One, because when there are 15,000 people per year receiving MAiD, it really means on a personal level, whether it is this year or next year or the year after, some of our own family members are going to be addressing that issue in some way, shape, and form. So we're going to encounter it on a personal level, have to deal with. And then on a professional level, we're going to have to deal with it. And I think the reasons for that will become more evident as I go on sort of with this presentation. It is worth noting here, so the blue graph that you see, if we go to 2023, that last bar, you will see that 96% of the people who received MAiD were in track 1, and 4% roughly were in track 2. And those percentages, as you can see, haven't, there's not the preponderance of MAiD since track 2 has been introduced very much leans towards track 1. That's not to say that what happens in track 2 is not important. It certainly is. On this one, I'm going to get you to, because there's a lot of numbers here. But again, if we go back to this front column, you will see here that in 2023, there were just over 15,000 MAiD provisions. But I want you to skip down to this point where the highlighter is. And you will see that in 2023, there are actually almost 3,000 individuals in Canada that died from another cause while they were on the waiting list for MAiD, which perhaps is a way of saying, again, that the vast majority of people receiving MAiD are in terminal stages of illnesses. You will also see, however, that there were over 900 requests made where the assessments concluded that the individual was ineligible for any number of the criteria that were identified. And we also see that there were roughly 500 requests made that were withdrawn, and those were probably withdrawn for any number of reasons, including the fact that sometimes when the patients actually got provided with more information, they chose some of the other options, and sometimes they withdrew because they didn't want to continue with the assessment process for various reasons. So the purpose of this slide is to show that the majority of people that received MAiD in 2023 had either cancer, or if we combine cancer and cardiovascular, that amounts to like 54% of all MAiD deaths. And this is really consistent with the two main causes of death of people in Canada, which is cancer and cardiac conditions. let me change gears a little bit and let me bring it down to a much more personal level. And I thought this was a very interesting obituary that showed up in the Globe and Mail in July of this past year. And it says, you can read, but I'll read it there. Catherine William Goddard, 92, and John Stanley Goddard, 94, of Calgary, Alberta, formerly of Toronto, passed away on Sunday, April 7th, 2024, in the presence of their immediate family and with the support of the Alberta Medical Assistance in Dying Team. After 67 years in love, John and Catherine Goddard shared a kiss and passed away together, holding hands and smiling. I think what this slide does is speak to the changing perspectives about MAiD. Of course, 20 years ago, we would never have imagined that we would see a death notice in a national newspaper that would speak to the notion that an elderly couple had died together in a way that was, as a society, sanctioned and approved. The stigma would have been too great. And now in this case, not only did it happen, but there's a level of comfort to say that the family are comfortable sharing that in Canada's national newspaper. Is that good or bad? And I think that the answer to that probably depends on what perspective one is coming from. There's an old saying that I'm familiar with from the East Coast that goes like this: where one stands on an issue often depends on where one sits. And so for each of us, we get to decide if the glass is half full or half empty. But more importantly, that decision may indeed change over time, depending on our own circumstances and circumstances of our family. Let me come back to this slide and talk about what we know from the Health Canada data. It shows that if you look at those three central graphs here, in both those slides, the message from this one is that it's the age groups of basically 75 to 84 is by far the largest age group, but the majority of deaths are occurring in that group from 65 to 85 plus. And we do know from the data overall that's submitted that the average age for MAiD death in Canada in 2023 was 77 years of age. Now, what about when it comes down to sex? And there are a bit of differences between track 1 and track 2. Here you will notice that men in track 1 out percentaged women, from men being about 52%. And I think that is perhaps not surprising, given that men have higher rates of heart disease and more severe forms of cancer that turn out to be terminal, whereas women have more chronic health conditions that they live with for a longer period of time, conditions like osteoporosis, osteoarthritis, dementia, higher proportion in women, and things like rheumatoid arthritis. And therefore, in track 2, you'll see the reverse. It is women that die from MAiD at a higher percentage compared to men. You may wonder, how do we gather all this data anyhow? And that is so all of this data has to be submitted by each MAiD provider on the occasion of a MAiD death in Canada. And it is consistent across the country from one ocean to the other. And therefore, it's the ability to collect uniform data that can then be put together this way by the federal government. Because remember that while the administration of MAiD is a provincial issue, the federal government is overall responsible because MAiD actually falls under the criminal code. In the slide, we're able to see that the most common source of suffering was indeed down here with the loss of ability to engage in meaningful activities, followed by loss of ability to perform ADLs. Now you see there's a whole host of things here, and obviously MAiD patients would have endured any number of those. But it's interesting, I think, that consistently over the years, since MAiD was introduced, it is that loss of ability to engage in meaningful activity that consistently comes out number one. So this slide speaks to 2022 data, and I'm saying 2022 as opposed to every other slide is 2023. And the reason for that is that in this last year's data, some new questions, some were introduced, and they started collecting this data in a different kind of way. So I thought it spoke more clearly if I went back to the 2022 slide here. And what we see is that the largest proportion whose natural death was not reasonably foreseeable, in other words, track 2, they died from neurological disorders. And when we talk about neurological disorders, we're talking about disorders such as Parkinson's disease, ALS, multiple sclerosis, dementia, and spinal stenosis. Now, this is a worthwhile place for me to say. You will note that I said dementia. And many of us might think about dementia as being a psychiatric disorder. And in the Canadian classification of diseases, dementia has never been viewed as a psychiatric disorder, but as a neurocognitive disorder that falls under a neurological disorder. And it's in that context, therefore, that dementia is not an exclusion for MAiD in Canada as long as the patient is capable to consent. And an important aspect of the consent aspect with regards to MAiD is that only an individual themselves can consent to MAiD. So a substitute decision maker, in other words, nobody else can consent to your death except the person himself. I find it very interesting to think about with MAiD deaths, where do people actually die? And this chart reminds us that the majority in 2023, 38%, died at home, with the hospital being the most second common setting. It is also perhaps extremely interesting to see that 22% of patients for MAiD died while they were in a palliative care facility. And that has certainly been a significant change from when MAiD was first introduced in Canada, where palliative care facilities excluded patients from having MAiD provision. So that's been, speaks to the evolution of things with regards to MAiD in our country. An important question is, where do the referral source for MAiD comes? And if we look at 2023, we will see in our numbers here, by far, the largest came from case coordination services. And that is because that's how services are organized in many regions of Ontario. And so you've got a central coordination service for a region where all the requests go through. We will also see a very large number came directly from the person themselves or another practitioner. And we will also see, however, that not a small number of referrals came from social workers, from family members, and from healthcare settings itself. And remember, the healthcare settings are made up of multidisciplinary teams who, and I think that again reinforces why it is important for the multidisciplinary staff to have a decent understanding about MAiD and the processes and some of the issues going along. Because ultimately, one way or another, the vast majority of us are going to be involved. So this slide speaks to kind of the global picture, which countries in the world currently provide MAiD in any form. And that list tells us, that Canada hasn't gone down that road alone, but we've had lots of company and there are lots of discussions in other countries. When we go to the next slide, however, the countries allowing MAiD specifically for mental disorders is indeed quite a bit smaller, and you will see that relatively short list there. And really, Spain and Colombia have come on board only in the last sort of couple of years. Whereas places like the Netherlands have legally and formally have had MAiD for 20 odd years. Now, an important debate as MAiD has evolved in Canada has been that ethical issue about healthcare providers' involvement in treatment where the individual healthcare professional might have had conscientious objection to being involved with MAiD in any way. And I want to say to you that the legislation and the policies in the professional colleges indicate fairly clearly that no physician or nurse practitioner can be compelled to prescribe substances for the purpose of MAiD or to administer MAiD. But that's only a part of the story. I think that it is worth knowing that where a healthcare professional has that conscientious objection, they have other obligations, and by what is known as an effective referral. And in essence, that is a referral that has to be made in good faith to a non-objecting, and that's an important word, non-objecting, available and accessible physician, healthcare professional, or agency. So you don't get to sit on it, and you don't get to say, I'll get to refer to a patient who will support the position of the physician. If it is, similar to if a patient were going to have a therapeutic abortion, you wouldn't refer the patient to the procedure to a physician who does not provide abortion services. And that's kind of the thinking in line sort of with this approach. At the time when this came about in Ontario, subsequent to MAiD being introduced, there were a group of physicians here in Ontario who wanted to challenge the constitutionality of the College of Physicians policy regarding referrals. And so they took the policy in the College of Physicians to court and objecting to having to provide this medical procedure or be involved with it in any way. And this worked its way through Ontario Superior Court and the Ontario Court of Appeal. And I'm going to read this out to you because I think this has an important message. And what the court ultimately decided, this is just a small portion, obviously, of what it said, but in summary, they said, the appellants have no common law, proprietary, or constitutional right to practice medicine. As members of a regulated and publicly funded profession, they are subject to requirements that focus on public interest rather than their interests. In fact, the fiduciary nature of the physician-patient relationship requires physicians to act at all times in their patient's best interest and to avoid conflicts between their own interests and their patient's interest. And I think that summarizes very well where the courts have landed in Canada on the obligations of physicians and other healthcare providers when it comes to being involved in MAiD issues. And that's the guideline that's going to be carry a lot of weight with all professional colleges. So what are some important points that I would highlight sort of about MAiD? One is that in acute crisis, MAiD assessments will not be completed. So that what that means in essence is that you can't get hospitalized under a Form 1 on a Friday and apply for MAiD and think you're going to get MAiD on Monday. So the assessment will be deferred when the patient is in acute crisis. The person must not have an illness, disease, or disability where social issues like housing, prices, or financial problems would lead to MAiD in the absence of a primary physical condition. So the overriding piece here is that you have to have that primary physical condition. You may have or may not have other social issues, but the social issues in the absence of a primary physical condition would not lead to MAiD. And that follows, I think, into the next point where for individuals where there are coexisting physical and mental health conditions, they currently will qualify for MAiD as long as the physical condition is the primary issue. So it's not as if today there are no patients with mental health issues that get MAiD. It is, they cannot get MAiD if the psychiatric disorder is the primary issue. But we know that there are lots of individuals that have severe physical issues that also have comorbid mental health issues. And the assessment's required to tease those things apart and establish clearly with evidence what is the primary condition. For track 2 patients, you have the serial assessments that can occur with a minimum of 90 days from the start of the initial assessment. And the idea is that that will offer some kind of adequate time frame for extensive and repeated evaluations. If we use the Netherlands that has been dealing with the issue of mental health conditions and MAiD for a good number of years, the average time frame in the Netherlands from the time of request to where MAiD is approved for any mental health patients turns out to be 10 months. And you can begin to imagine, therefore, in that 10 months, there's a lot of reassessments. There's a lot of involvement with collateral sources and a lot of involvement with families and reviewing previous clinical records and the like. And also important to note that a refusal of reasonable treatment options results in being ineligible for MAiD. So it's not that one can just lay out that there are treatment options. There has to be an agreement between the physician or NP and the patient that reasonable options have been fully carried through with in terms of treatment for a patient. So what are some of the challenges that we're seeing in 2025? I think I'll summarize them by saying the notion of normalizing death as a treatment option, some people struggle with. But if we go back to the Healthcare Consent Act and the definition of treatment in Ontario, it is really anything that is done for either therapeutic, a palliative, cosmetic, or to reduce suffering sort of the patient. We see when we look at the MAiD data across the country is that there are low consultation rates with patients' family physicians, and that's about 35%. I think what that says is that there's probably a lost opportunity to get better collateral history with some family physicians in terms of understanding a patient's situation. We've identified that the issue of assessor provider expertise is an issue. And there it is that the Netherlands went down the road of requiring formal psychiatrist evaluation for every patient. Here we've watered it down a bit, and I suspect that that's going to continue to be an issue that we likely will see some evolution on as the legislation evolves here in Canada. There is the issue of educating assessors and providers to distinguish suicidality from MAiD requests for other reasons. And I think that in part ties in with my previous point about the assessor provider expertise. And probably psychiatrists spend a lot of time trying to sort out that issue about suicidality. And we come to the issue that I won't reinforce except to say the difficulty in defining incurable mental illness, disease, or disability that Doug defined, but defining something, being able to operationalize it, are sometimes two different things. We identified the challenge of dealing with the social stressors, so that when you have housing, finances, food insecurity, when you got to sort out how do they contribute to a person's mental disorder and how does it influence their eligibility for MAiD? The absence of provincial oversight. What I mean there is that most of the accountability regarding MAiD actually occurs once the patient has received MAiD. I think there's a school of thinking that says, particularly for track 2 patients, there should have to be something the equivalent of the consent capacity board, where the approval by the physician or nurse practitioner actually got to go to another level for review before MAiD can occur. Then there's the issue of doctor, nurse, practitioner shopping if MAiD is denied, because there's no timeline that says if you're turned down by me today, that next week you can apply to somebody else. Now, I see this happen, and I think most of us are smart enough to be able to figure out that if a patient has already been turned down, we are going to be requesting that record from that assessment previously to determine what that assessment showed and why they were turned down. And I think a challenge will be educating all healthcare providers about their role and responsibility in MAiD. Currently, there is an excellent educational program that at the moment is limited to physicians and nurse practitioners that is rolled out across the country. And I suspect that in the next year to year and a half, one will see that rolled out in a further kind of way. So if you get the opportunity to be able to access that, it is made up of 7 or 8 different modules and takes about a minimum of about 30 hours of continuous work to work your way through it, but it's actually done superbly well. And then there's the issue of determining the advanced state of inevitable decline in capacity. So in my summary points about MAiD will be that MAiD continues to be in a state of evolution in Canada. And I think that metaphor that says the notion of flying the plane where we are building it relates well to what's happening sort of with MAiD. The next point would be that MAiD accounted for approximately 4.7% of all Canadian deaths in 2023. Where will we land? That I think that I'm not sure that anybody really knows the answer to that. The Netherlands has landed at about 5% and they've been there consistently. But we have some different criteria here in Canada. And as MAiD becomes more and more socially acceptable, we might see those percentages increase, although last year they increased at only half the rate of previous years. We identified the establishment of the 2 different pathways for MAiD, depending on whether death is reasonably foreseeable or not. And I'm noting that there's a multitude of unresolved clinical, legal, and ethical challenges that will continue to evolve over time, and particularly in regards to individuals where the sole underlying medical condition is mental illness. So I put back to you, is glass half full or half empty? That's a complicated question with many different variables that in the end will determine your position and my position and your family's position on this issue. So what's the direction for MAiD for primary mental illness? I think that will depend on government legislation. And we've already heard that if the next Conservative government were to be elected in Canada, they will be put on hold and imply that they would reverse some of the current MAiD stuff in Canada. I will say to you that ship has sailed. There will be no reversing the current stuff. And ultimately, the government may indeed decide not to proceed. But there are some cases working its way through. Currently, the Ontario Superior Court that will ultimately land at the Supreme Court of Canada, and it will, as in the start of MAiD, it will be the courts that will give direction to the government on what will occur. I thought I could not finish this part without referring to Sue Rodriguez. And she was a woman who lived in BC and at a very young age developed ALS, and a decline started to occur very quickly. She is regarded as one of the pioneers in Canada that advocated very strongly at a national level for MAiD. And in 1992, she, in a very debilitated state, gave a videotape session to the House of Commons because physically she wasn't capable of getting there. And one of her comments was this one: "If I cannot give consent to my own death, whose body is this? Who owns my life?" And I think that summarizes the perspective of many individuals who are in support of MAiD. So let me quickly come back to those questions that you wrote on your hand or on a piece of paper in front of you. Let's go through them quickly. The individual must have a terminal illness to be eligible for MAiD? No. We see that we have track 1 and track 2, and so it doesn't always have to be terminal illnesses. The person cannot have refused treatment that the doctor believes will be effective in treating his or her condition. The answer there will be false, and it's false because it's not the physician that decides what treatment somebody should have. Ultimately, it has to be a joint coming together, but the doctor alone does not make that decision for an individual. A person with a physical illness and a psychiatric illness can be eligible for MAiD, and the answer would be true, as long as, with the caveat that the physical illness is the primary issue. Any healthcare professional can initiate and engage a patient in discussion about MAiD as a treatment option. That is true. And that is part of the reason why we all need to be educated, because patients will bring up those issues sort of with all of us. And I would be remiss if I didn't say, when I've been doing some MAiD assessments, I have reached out to social workers and other healthcare professionals to get copies, request copies of their notes that can be used to help me evaluate what's been happening with treatment and what the goals and what's been worked on, and what sort of progress a patient has made. And the fifth question is, a person with a primary diagnosis of dementia is not eligible for MAiD. And of course, that particular one we know would be false, because I already pointed out that dementia falls under the neurological disorders. And again, as long as that patient is capable of providing consent. And on that, I've taken up more time than what I should have. And I'm going to remind you that in coming days, I want you to take a couple of minutes, complete an evaluation form, and give us some honest feedback. Over to Nicole.
Thank you so much. It was a great and very informative presentation, so we appreciate it. So we do have a couple questions in the chat. The first one says, for RFND, how are individuals that have potentially become nonverbal or may have additional cognitive impairments from disease able to provide final consent, or are they not allowed to move forward if they fall in these categories?
Excellent question. So it is complicated, but I will say to you, there are patients that have great difficulty in communication. You're going to be expected to use every means of communication possible. Sometimes people can't articulate, but they can write. Sometimes, in fact, you can do an assessment that indicates nodding. Now, you're not going to make that decision on the basis of one nod to one question. That would be if nodding leads to adequate answers to every question sort of along the way. So there are ways to be able to do that. But sometimes what the patient may have deteriorated to a way that when you get to that stage, the patient is no longer able to provide consent. And therefore MAiD could not occur.
Perfect. Thank you. Another person asked on the slide where it says MAiD by medical condition, what are the others? What are some of the
Very
others?
good. Very, very good. So that is a whole host of other things that don't fall into those categories of respiratory conditions and the like. So let me say to you, a patient with severe chronic pain from, let's say fibromyalgia, that you were disabled to such an extent. So it's the category that doesn't fit the conditions that fit into any of those other ones that we've said. And it really is a big grab bag of everything else. And sometimes things like, so I just mentioned fibromyalgia, but there are lots of chronic conditions. It could be, yeah. So I think that's what I would say there.
Perfect. And then Sharon addressed that the slides will be posted on the CWSO website. Another person asked, patient can refuse treatment, yet, quote, refusal of reasonable treatment options, quote, makes a person ineligible for MAiD. How and who defines what's reasonable?
Did you want to say something about that
You
one to
can-
begin with? Or
you can
I'll
start.
start.
You can
I'll
start.
start to say that in those situations, the discussion about what is reasonable is a joint discussion between the physician and the patient. Let's take a mental disorder. Let's take the issue of somebody that has a treatment refractory depression that has been in treatment for the last 10 years, and they have a psychotic depression, but they also have never agreed and never been provided ECT. Well, I'm going to say to you, ECT is the #1 treatment for psychotic depression with about a 95 to 96% complete resolution. It would be unthinkable to say that, therefore, even if a patient was objecting to ECT and they had a psychotic depression, that we would proceed to give them MAiD when something that is a well-defined with a spectacular treatment result, that we would proceed to MAiD. So in that particular case, for example, that difference between how the physician would see it and how the patient would see it would mean there's disagreement, and we would not proceed to MAiD in that particular situation. Doug, do you want to add anything?
No, I think you touched on it at the beginning. It's that joint sort of agreement or discussion.
And that is different where, when it comes to suffering, the physician doesn't have any input on what the suffering, because the suffering is a really, really individual thing. And what one person sees as suffering and what is not tolerable, or what is tolerable or intolerable, will be different between every one of us that is online here today.
That's a really good point. Thank you. And I think there's one last question. Are there any initiatives in action to advocate for those who have mental illness as a primary diagnosis in preparation for the 2027 evaluation?
Doug?
I think one of the larger organizations in Canada that I'm aware of that is on the advocacy side of things would be Dying with Dignity Canada. That's the one that I'm most familiar with, but there might be others.
Yeah, I think that there are groups like the Canadian Psychiatric Association that has presented briefs to Parliament and to the Senate, and that outline the complexities both for the population, but also where there may be some advantages, and trying, and it's the Canadian Psychiatric Association together with some other groups across the country that were instrumental in getting the federal government to slow down the process of proceeding with MAiD in the last year as it was scheduled. I think that there are groups like the educational piece for physicians around MAiD and nurse practitioners, and that will be that's been rolled out across the country, and we see more and more physicians sort of engaged in that education. Doesn't mean that they're all going to be assessors or providers, but getting educated about this is important. And I would remind a group that if you have the chance, you might go on and take a look at the Canadian MAiD Assessors and Providers Association website online, and they have their information on the courses and the modules. But there's also a number of superbly interesting documents on that, including a document on the MAiD and mental disorders.
That's fabulous. Thank you for sharing those resources. I believe that's all the questions we have. And I know we're a couple minutes over, so I just wanted to thank everyone.
Nicole,
yes.
Can I just jump in? There was one more
Absolutely.
question.
Oh, I apologize.
No, that's okay. The question was, I had a patient I had informed of the option of MAiD. When they approached the family physician, they were told no, it wasn't an option. I believe the family physician was not in agreement with MAiD. Can patients self-refer?
Yes. Yes, absolutely.
Thank you.
Sorry, someone had asked if the website you were referring to, Dr. Furlong, is CAMAP, Canadian Association of MAiD Assessors and Providers.
Yep,
okay,
that is correct.
Great. Okay, thank you so much, everyone. And thank you again, Dr. Furlong and Doug, for taking the time to share this really insightful information. And we look forward to getting some feedback for you folks and sharing more information on upcoming events.
Great. Thanks very much to all of you for joining, and thank you for the work that you do every day.
Take care, everyone.
Bye.
Thank you, everyone. Thank you, Doug and Dr. Furlong. That was wonderful.
I hope it was helpful in some way. It's kind of, what we really, and, nobody has enough time to be able to do the education one wants to do. This really would be a session that we would have needed to have presented like in a 3-hour time frame, but we all live with all kinds of limitations about what we can do, so we try to make the best of it. And if somebody learns even 2 tidbits from it that's useful to them, we'll be happy.
Well, and maybe while I've still got you, if you don't have to run, there was an article in the New York Times yesterday about a woman in Germany who was diagnosed with dementia, and she wanted to create an advance directive. So the advance directive, she had said, when I'm no longer able to recognize my children, or when you have to put me. But so when she got to that point, or when they anticipated getting to that point, it was not considered legit because she didn't have capacity anymore.
Yep.
Right. And then there was the question about the subjectivity of when I can't recognize them. So do you not recognize them today? Do you not recognize them next week?
Yes.
Maybe in between. Yes. So it sounds like there's a lot to sort out.
There is. But you raise a really important issue, and I'll quickly say it to you this way. Number one, there is in Canada, once the mental health condition direction has been sorted out, the government has that the next issues to be sorted out is the issue of advance directives for people with dementia. And then subsequent to that, going to be what they call mature minors for those under the age of 18. And so that we know that work is already, there's background work that's occurring in that, but that's the direction things are going to go. However, when it comes to MAiD in Canada, Quebec has always been ahead of the rest of the country. And I want you to know that in December this past year, Quebec doesn't like falling in line with direction sort of from the federal government. I think I can say that, really. And they've done their own thing. They were the people that pushed this forward to begin with. The Quebec legislation as of December recognizes advance directives for dementia in Quebec. And you're going to say, well, how can that be, given that if the criminal code is a federal criminal code, does it make a difference what Quebec decides? And interesting, the federal government already made clear, just as they did when Quebec took the other steps ahead of all the other Canadian provinces, they've already decided they will not prosecute any healthcare professional involved under the criminal code, involved in the provision of MAiD, where there's an advance directive for this population in Quebec.
Wow,
So
that's interesting.
I'm going to say to you, stay tuned, because I can guarantee you that is an issue that is going to be coming to the rest of Canada, and how quickly we get there will depend on which government stays in power and how much they have to work their way through the courts, which will take longer, but we'll get there eventually. Because the problem in Canada that most people see is that when we talk about people living with chronic conditions, all you have to do is go to nursing homes and walk in, and you will see a large proportion of people that are living with chronic conditions. And when you have dementia, you're living anywhere from 5 to 12 years with dementia, and sometimes suffering a lot. And patients want to be able to have those decisions made when they are capable of making them, and their decisions stand should they become incapable.
And I think that's where the rub is going to come is, do they need to be reassessed for capacity?
The issue will be, the whole idea of the advance directive is that even if you've lost capacity, once you've made the decision and put in place an advance directive, it's the advance directive that would carry weight.
Supersedes. Yeah,
Yeah.
that's very helpful. Thank you. Because I thought,
Yep.
my heart went out to this woman who made all of these decisions, and they said, sorry, you don't have capacity, you no longer qualify.
What you've identified happens every single day in every province across this country right now.
Yeah. Well, and on a personal note, we went through that with my father, who, when he
Yeah.
was capable, he had never put anything in place, but that's what he said,
Yeah.
and then he became so unwell. The doctor said, sorry, he doesn't have capacity anymore.
Yeah.
That ship sailed now.
Yes, yes. Which might be a way of me saying to you is that the more MAiD gets talked about in society, the more likely it is people like your father and my parents, when they were alive, would have gotten knowledgeable and aware of it to some extent, and might have been able to address it earlier when they couldn't address it later on.
Right. Thank you so much for staying the little extra and answering
No,
my
not a
question.
problem. Not a problem. Nice to see you, and nice to hear your voice again.
Nice to see you too, and nice to meet you, Doug. And you guys take good care, and hopefully the weather will be good for the next 2 weeks here in sunny Canada.
Yes, and you enjoy your vacation.
Yeah.
Thanks so much.
All right, then.
Take good
Bye.
care. Thanks.
Bye.
Thanks, everyone. Bye-bye.